Hello, I'm Dr. Laukkanen, and I'm going to be talking about non-invasive breast cancer. I'm going to focus on radiation treatment because you may have been referred to me to discuss that possibility. And the first thing is that while we're going to delve into the details of non-invasive cancer and radiation, uh, the big picture is about you, um, because all decisions are going to be made in the framework of your own preferences and your general health. So what is in situ or non-invasive breast cancer? Well, briefly, it's the best kind. If we look 10 years down the road, um, the vast majority of people who've had this diagnosis are doing well. And it's often found on a screening mammogram. For example, a report can describe a tiny little new density not seen on a previous mammogram. And it happens also that very early breast cancer, for reasons that we don't fully understand, can lay down little bits of calcium that can be seen on mammograms. So there can be either a small or a larger amount, as in this picture, of little telltale kind of salt-like grains, microcalcifications that are a tip-off to the presence of non-invasive cancer. And to look at things in more detail, the breast was designed for milk production and transportation. So a set of little uh, transport tubes or ducts that are designed not unlike the branches of a tree, with tiny little twigs converging to bigger branches and even bigger than extending out to the trunks of the nipple. And if we were to look at the linings of those tubular structures, that's where breast cancer can get its footing. And it can either be in a single duct or in a family of ducts or an even larger section. And if we look at what's happening, normally those ducts are lined with a neat, regular layer of cells. And for reasons that we don't fully understand, those cells can start building up abnormal numbers, abnormal forms. And if they're abnormal enough, that's breast cancer. And just to really draw the line between non invasive or in situ breast cancer and invasive breast cancer, the non invasive cancers are confined inside the lining of the ducts. And because those duct walls are very delicate and we might regard them as thinner than the finest tissue paper, if a cell is biologically able to live outside the duct walls, it does. So non-invasive breast cancer is a biologically earlier stage where the cells haven't developed the capacity to live outside their native home. And the first step, as you have been through, is the biopsy typically. And that biopsy has shown non-invasive cancer, and the pathologist says a few more things about it. For example, comments on the grade or the appearance of the cells. And we can think of cells as having a very mild or bland appearance and having a bit, quite a lot like normal, or we can think of them as being uh, more different than normal. And those are the categories of the intermediate and high grade. And the intermediate and high are generally sort of grouped together in non-invasive cancer. And then when a diagnosis confirms non-invasive cancer, usually surgery is done with some kind of localization because these things are often not felt as a lump and easy to differentiate from structures around. And the surgeon, they do an amazing job. They remove a tissue segment that contains the abnormal area. Then the pathologist looks at how big was it, confirms that it's all non-invasive cancer, and importantly, looks at is it clear from the edges, and that in fact can be sometimes a challenge to achieve. And the pathologist also looks for features that might suggest more active division of cells. And one example that you might see on your pathology report is this idea, is there any of what's called necrosis? And that's cell breakdown within the duct. And if you imagine the cells piling up inside the duct, and if there's enough of them, the ones in the middle break down, and that's the so-called necrosis. A feature of potentially the higher grades, although intermediate grade can have that as well. So just to summarize, when the surgery has been done, the pathologist has done their work, they comment, what is the overall size and extent? Is there more than one area? What is that grade? Absolutely confirming that there's no invasion, and also checking that the margins are uninvolved. And if they are involved, the surgeon generally will comment on that. Some margins can be extended and made bigger, and there are a few cases where they can't. And the other thing that's looked at is what is the nature of the surrounding tissue? Is it just ordinary bland breast tissue? Are there what are called fibrocystic changes that are benign? Or is there anything atypical that might be kind of a marker of risk for the future? And then radiation is considered as a possible next step. And the alternative is just observation. And if a person has very low risk DCIS and or they might have the particular preferences or general condition, the observation is the alternative choice. And the kind of cancers that might be optimally considered for observation are those that are the lowest grade, the smallest, removed with wide margins, and none of that necrosis, because historically many of those cancers have not come back. Now, radiation treatment we might think of as extra insurance to lower the risk. And the idea is that all the known cancer is gone, but if there's a chance of having a few microscopic cells lingering in those breast ducts in the neighborhood or perhaps further afield, that radiation treatment will lower that risk of recurrence. So what is it? High energy X-rays made by special machines that have the ability that they can inactivate many types of cancer cells. Here's a typical radiation machine. A person, when they have these treatments, might spend up to half an hour in the treatment room, but the actual radiation beam time is actually very, very short, just a few minutes. And radiation starts with a treatment planning session, the so-called CT simulation, where attention is given to positioning and a CAT scan is taken to enable the planning and setup of treatment. And at that visit, especially if it's a left-sided cancer, there's some work to check breathing and consistency of breathing. And this just shows radiation work in progress, and you can see that there are two beams that basically skim from one side of the breast to the other. And a lot of work is done behind the scenes to make the radiation distribution uniform, even though the breast is not a uniform structure. But the concept is simple. Radiation beams that go across the breast is shown there. And if we look at the tissues that are going to be potentially treated, there's the skin, the breast tissue itself. The breast sits on the rib cage. And as you can see when you look at the lower part of it, that the lowest part of the beam skims across a little sort of new moon-shaped rim of lung tissue that's lying immediately under the breast. And typically, for non-invasive breast cancer, the treatment prescriptions are 16. And under some circumstances, a little extra radiation is added to the area where the lump was, or the abnormal finding was removed, and often 4 additional treatments. It ends up taking, in that case, about 4 weeks, 5 days a week to complete the treatment. And radiation, because it impacts the normal tissues, has some side effects. And usually not much is noted in the first week, maybe a little in the second week, and there can be some slight reddening of the skin, maybe a little bit of tenderness of the treated breast, and possibly even a little bit of swelling. But afterwards, into the third week, and for a period that might extend 3 to 4 or so weeks afterwards, definitely some tenderness, some fullness, and skin changes that are not unlike a sunburn. Tanned skin, dry pinning of the skin, more progressive shades of pink or red skin. And where there are vulnerable skin folds, especially where they can be exposed to friction injury, there can be more irritation yet. Just to go over that, because that's what people can notice the most, it's at the lower margin of the breast and where the breast can rub against the upper inner arm. Uh, those friction effects that are normally always being repaired aren't repaired normally during the radiation treatment, and there can be little areas of even the surface skin loss. And special care is needed for that area, and then it ultimately heals. Now, all of those skin changes typically settle over a few weeks. Sometimes there can be some lingering variation in the amount of tanning of the skin, and over months to even years, the skin can potentially be a little bit more fragile, and sometimes tiny little blood vessels can be seen if one looks closely just under the skin surface. Now, the tenderness and fullness that can happen because there's more tissue fluid in the breast can linger. It depends, again, if the breast has a portion that is dependent, that that can happen in up to 10% of cases. But for a small breast, it's very unusual. And if one looks at 6 to 12 months after the treatment, between 5 and 10% of people will note that there is some lingering breast tenderness, but often not enough to actually interfere with quality of life measures. And the breast can feel a little bit more firm. And some people find when they have radiation treatment, they feel a bit more tired. It depends on the person. Obviously, coming to a hospital setting for treatment each day, that itself can be tiring. Now, when the treatment is all finished, what things do we need to think about for any possible late or delayed side effects of radiation on normal tissue? And usually there isn't any detectable impact. But if we describe for completeness all the structures that have the potential to be impacted, well, the skin and soft tissues of the breast, the ribs under the breast, the lung that's immediately below the breast, and on the left side, depending on the position of the heart and the technical aspects of treatment, there's a possibility of some radiation encountering a component of the heart structure. And then, of course, there's concerns that have been discussed about are there any second cancer risks and so forth. And if we were to look at each of these in turn, the skin and soft tissues in an average person, apart from what I've discussed already, they just settle. But what if a person had an exceptional normal tissue sensitivity to radiation? Then radiation could cause a very fine scar tissue to form, and that could cause retraction, firmness, and tenderness, and perhaps some greater vulnerability of the skin. In my practice of many decades, I've seen exactly one case like that, but you can never say never. The rib cage under the breast, which is exposed to radiation, in theory, is slightly more predisposed to osteoporosis with the passage of the years. That's thinning of the bone. But if one takes a proactive approach to bone thinning as one ages and lowers the overall risk of osteoporosis, that impact of radiation would be very, very unlikely to be observable. Most of the time, the little bit of lung that is exposed and must be exposed to the radiation beam isn't noticed. But in up to anywhere from 3 in 1,000 to 3 in 100, depending on the number of factors, there can be a localized inflammation of the lung under the radiated breast, and that is called radiation pneumonitis. It is treatable with anti-inflammatories. It rises a few weeks, typically to a few months after the radiation treatment, and runs its course. So it's like a localized plate-like area of pneumonia, but is not caused by an infectious problem, but rather a reactive inflammation to the radiation. There's a lot of controversy about whether radiation affects the left side of the heart, and that's very much work in progress. And a lot of work is done really to be on the safe side to maximally avoid radiation coverage of the heart. And then typically, the left side is treated with a person holding their breath so the radiation beam is more widely separated from the heart. As far as second cancers are concerned, the one thing that one has to think about is if a person is a smoker and continues to smoke, there's a measurable increase in lung cancer risk years down the road. But for other cancers, a careful look has not shown that one can detect an increased cancer risk on a statistical population basis. So it's a very, very rare event. So let's look at the treatment benefits. The goal is to lower the risk of the cancer returning, and it depends on the details. A rough rule of thumb is whatever the risk is without treatment, the risk is reduced by nominally 50%. So there's if you look on the internet, the Memorial Sloan Kettering has what's called a nomogram that predicts the benefits of radiation treatment for DCIS or duct carcinoma in situ, depending on the age, how it was detected, and some features of the cancer. And this is just an example that you plug in some numbers and it'll say this would be a recurrence with no radiation at 5 years and at 10 years. And if you add the radiation, this is how much the risk is reduced. And those might be some numbers that one might see with an intermediate, not too big area of non-invasive breast cancer. So notice there's a hormone treatment, and there is an option that medications taken over the longer term that impact the hormonal environment of the body further decrease risk. But everything has a risk-benefit ratio, and we're going to focus on the radiation here. And just to review, that there are non-invasive cancers that when you look at, well, gosh, that's all the bother of radiation treatment. How close am I to that low-risk category where I can just not bother with the radiation? And the point to remember is that radiation is a tool that doesn't eliminate risk, it lowers risk, and your personal risk preferences are the governing factors. But the goal overall is to avoid recurrence, because about half of recurrences are in fact invasive recurrences, and those carry a biological impact, and that's why radiation might be considered as the typical standard of care after non-invasive breast cancer surgery. There are alternatives. A person can choose to have the breast removed, and that's obviously been discussed with the surgeon, or a person can just choose not to have the radiation and have the surveillance. And there are those hormonal medications that we touched on. If a person goes ahead with radiation, it's fairly straightforward. They have their planning. Typically about 3 weeks later, the treatment starts. They have visits with the therapy team on the unit and see the nurse if they're having issues and the doctor at the end. And then afterwards, the family doctor coordinates long-term surveillance. And thanks very much for your attention.